Okay, I was asked to talk about, to address the question, what to do when all else fails. So I'd call this, with my misspelling on the title slide, unconventional therapies. And in the context of this talk, I'm going to make, I have two take-home points I want to make for all of you. And the rest I had to fill a half hour. So there's two important points here. And the first one I'll make right now. If you have a patient on what we'll define as conventional therapies, evaluate the patient and figure out why conventional therapies aren't working. And I'm going to give you two examples of this. And we'll start with 6-MP azathioprine non-response. You have heard about this in other contexts. In a patient who has failed everything else, what can we possibly do here? And I'm going to talk about two primary clinical scenarios. Patients who are primary azathioprine 6-NP non-responders. Is this someone that you want to add allopurinol on, for reasons we'll discuss? And I'll briefly mention, and briefly because, as with many things I'll talk about, this isn't a very evidence-based talk because there's not a lot of evidence for these salvage therapies, and I'll point out where the data gaps are and where there is evidence as we move on. In someone who's an anti-TNF failure, can you add azathioprine 6-MP? Well, we know from work of Marla and others that 6-MP is metabolized down several pathways. What we're looking for is the therapeutic moiety is the 6-TGN levels. And there's an enzyme xanthine oxidase which will send 6-MP down this 6-thiouric acid pathway, and in patients who have high activity of this enzyme, we talk about them shunting towards the non-therapeutic metabolites, and so this has led to the notion that if we could inhibit xanthine oxidase with a medication like allopurinol, we may be able to affect therapeutic responses in patients by increasing the 6-TGN levels. And this has been shown in a few studies now. And if we look at patients who are treated with allopurinol, you see the 6-TGN levels go up, the 6-MMP levels go down, and this has been correlated with therapeutic responses in patients. And this is a potential strategy, but one that I think needs to be, at least in part, taken very seriously. And the problems with this strategy is, number one, bone marrow suppression. When one wants to undertake this strategy, I think one needs to do this with appropriate trepidation. You want to use very low levels of azathioprine or 6-MP. And let's understand why you would be using this strategy. Would you use allopurinol as an attempt to keep people off of a TNF inhibitor? In my book, this isn't one of the things you want to do. I think that this is a strategy that that requires very close follow-up and monitoring, and so as an anti-TNF sparing strategy, I just don't see the rationale. If this is a strategy to try to optimize combination therapy in a patient who's on a TNF inhibitor, I would ask you to consider methotrexate rather than maybe playing around with this labor-intensive strategy that may have some side effects if you don't have a lot of experience here. And so where I have used this in the past is in really patients who don't have any options, perhaps as a in someone who meets the criteria of shunting the 6-MP metabolites down the wrong pathway after anti-TNF failure as a monotherapy. So maybe a very small niche for considering something like this. Now, what about adding of azathioprine or methotrexate to someone who is failing anti-TNF as a way to optimize responses? And I think we're doing this all the time, and I'm not quite sure what we're doing by this, and there's very little data. There was one abstract presented at DDW suggesting that maybe you could rescue some patients. It would be nice to correlate these strategies with levels of the anti-TNFs eventually, and to really understand the mechanism behind the combination effect in someone who is failing an anti-TNF better. My concern with this strategy, having done this for a while now, is this really too little too late, and are these really refractory patients who, if anything, we may be buying time, and we just don't know. There's data gaps in this regard. What about anti-TNFs? And I think an important point that I want to make, as you go from your first to your second to your third anti-TNF, you get diminishing returns for each one. And this is data from rheumatoid arthritis, and basically you could see as patients go from their first to their second to their third anti-TNF, the overall response rates and the time of responsiveness is less and less and less, leading the rheumatoologists as well as us to conclude by the time you hit your third anti-TNF, you're probably past the point of diminishing returns. Now, there's a nuance here, and it depends on why you failed an anti-TNF. And if it's replaced for adverse events, people do better than if it's replaced for other causes, which by and large is loss of response. Now, again, I'm not going to talk much about this because this is whole other lectures, and we're into a more educated area now where we may be able to use levels and antibodies to anti-TNFs to help make these decisions. And perhaps we could do better with the second and third TNF inhibitor if we understand the mechanisms behind why patients are failing. And this has led to these treatment algorithms that you've seen, and again, I'm not going to discuss because this is a hot topic and a whole other can of worms that it merits its own lectures and symposia. But in patients who are making antibodies, in this case to infliximab, we now know there's antibodies to adalimumab as well, which are commercially available. Patients, strategy would be to change to another anti-TNF inhibitor. If there's a therapeutic concentration, this is an important point. Does the patient have active disease? You want to evaluate for disease activity. If the patient does have active disease, you could think about increasing the dose of the TNF inhibitor, possibly changing to a different mechanism of action, which we'll discuss in a little bit. And if there's low levels of a TNF inhibitor in the presence of active disease, these are the patients who may benefit by dose escalation. You want to assess your patient, so because surgery may be an option, and surgery is not such an unconventional therapy. And let us not forget that patients with Crohn's disease who have recurrent obstructions, perforations, fistula, or abscesses may in fact benefit most significantly from surgical intervention. So this is really part of our algorithm about thinking about this. There are patients who have limited disease for failure of medical therapy with Crohn's disease, and of course with ulcerative colitis, that you want to consider the surgical options, perhaps earlier in the disease course before you start burning through medical therapies. Okay, so let's go through some of the unconventional immunotherapies that you may want to consider in patients who have failed all of our conventional therapies. Now, what about cyclosporin? You're going to hear more from Russ Cohen later in the day about cyclosporin in ulcerative colitis, but in Crohn's disease, there's really limited efficacy that has been shown, and there's been meta-analyses looking at this, and the conclusion of the meta-analyses, there was really no benefit in Crohn's disease. The cyclosporin enthusiasts in the world may argue that, well, the one study that looked at the highest dosing of cyclosporin in Crohn's disease actually did show a benefit. It makes sense that a potent T-cell inhibitor would work in Crohn's disease, but when we're talking about doses higher than 7 milligrams per kilogram, this certainly brings up the question of a world of toxicities that we need to address both short and long term as well. So I think the efficacy data in Crohn's is limited. I will save the efficacy data in ulcerative colitis to Dr. Cohen, but at least in ulcerative colitis in patients with IV steroid refractory disease, there's at least evidence out there. I'm showing you the results from this, the famous Simon Lichtiger and Dan Present study in 20 patients that was published in the New England Journal, where the study was stopped early because 9 of the 11 treated with cyclosporin did well compared to 9 of 9 who failed therapy with placebo in this group, and you'll hear more about this from Russ. So there is evidence, at least here, for a salvage approach. Well, there's another T-cell inhibitor in the same family as cyclosporin, tacrolimus, where we do have some evidence for early responses in refractory ulcerative colitis, and I'm showing you a summary of a Cochrane database meta-analysis, and just look at the bottom bar here summarizing the experience in refractory ulcerative colitis, where everything to your right of this line favors tacrolimus over placebo, and here the summary of the study suggested a benefit 2 week in clinical improvement 2 weeks after initiation of tacrolimus. There was no benefit demonstrated in terms of maintenance. In Crohn's disease, this slide says level 3 evidence, and there's no data on it because there really is no level 3 evidence in Crohn's disease. There was some small studies suggesting closure of fistulas at higher doses as a primary endpoint, but these doses were not very well tolerated. So in terms about thinking of cyclosporin or tacrolimus as salvage therapies for medically refractory IBD, there are problems. There are adverse events as a result of immunosuppression and nephrotoxicity. Levels need to be followed closely. Again, this is something that is going to require intensive monitoring. There's really no significant efficacy signal for either of our calcineurin inhibitors in Crohn's disease. And because of long-term effects, we still need to think about an exit strategy here. I think the long-term side effects of these therapies are going to be prohibitive. So moving on to something that is near and dear to Dr. Korzenik's heart, Segramestin, or GM-CSF. At our center, some of my colleagues have used this in patients who have failed multiple TNF inhibitors and other medical therapies. GM-CSF is a hematopoietic factor that stimulates cells of the intestinal innate immune system, going back to Josh's talk. And this also has effects on some innate immune cells to modulate the initial phases of antigen processing or stimulation. So there's a rational theory behind why this may be effective. However, looking at the large phase 3 studies in terms of response and remission, if we look at the overall data, there was no significant differences between Segramestin and placebo. However, as Josh knows, if we look at sub-analyses, particularly that account for the high placebo response that was seen in Eastern European countries, there were definitely signals of efficacy in the U.S. and Western Europe, and in sites where there were lower placebo responses and more experience perhaps with clinical trial patients. So this is something that I think is of interest moving forward in the future, and is something that's on the laundry list at least at our center for end-stage salvage therapies. There are side effects associated with this. In the study, there was 25% dropout by week 8. And there's problems as well. I think with several of the salvage therapies I'll discuss that are really off-label uses, there's going to be problem with access, cost, and copays. That goes without saying. With Segramestin in particular, this is something that requires daily injections as best as we know for induction. There's intolerances, there's bone pain associated over the short term, and there's really not a defined maintenance strategy for this therapy yet. So I know Dr. Korzenik gets calls all the time about patients who were induced with GM-CSF and says, so what do we do now? And I think Josh's usual answer is, who knows? But well, we'll let him address this later. Okay, so maybe here's maybe the best kept secret in Crohn's disease is that there is an FDA-approved option for severe refractory TNF inhibitor refractory Crohn's disease that most of us, for reasons that I'll explain, have forgotten about. And this is an agent, natalizumab, which is a monoclonal antibody that binds to the alpha-4 integrin. What the alpha-4 integrin is a zip code that is expressed on the surface of circulating leukocytes in the bloodstream that tells these cells that it's time to go to a mailbox, which would be sites of inflammation throughout the body, including the gut and the brain. Natalizumab is a highly effective and FDA-approved therapy in multiple sclerosis, and it was also FDA-approved for medically refractory Crohn's disease, and we're not going to talk about some of the variations of the themes of this theme that will lead to gut-specific therapies in the future, but just to remind you of some of the data that led to FDA approval in refractory Crohn's disease of natalizumab. Natalizumab was shown to be essentially equally effective for maintenance of remission at month 6 and month 12 in the overall intention to treat population compared to placebo, but was equally effective in the subgroup of patients who had failed a TNF inhibitor in this clinical trial experience. So here's a different mechanism of action in someone who has failed one or more than one TNF inhibitors that would be worth considering. So why have we all forgotten about natalizumab? And it's because of the occurrence of a significant adverse event, which is the development of progressive multifocal leukoencephalopathy, or PML. This is the reactivation of a JC polyoma virus infection, which then sets up shop in the brain. Because natalizumab keeps circulating leukocytes out of the brain, we're essentially eliminating our body's ability to surveil against this virus, which is why these infections go unchecked. Well, there's been a bit of an advance in this area that I think is important to consider when we think about patients with very refractory Crohn's disease. The risk factors for PML has been long duration of natalizumab treatment, particularly patients who have had it for over 2 years, prior immunosuppressant use, which is going to be all of our patients, and positive anti-JC virus serology, which became commercially available in 2011. So there's an ELISA test that will actually allows us to determine whether our patients have been exposed to the virus that causes PML. And there's been some modeling done based on the results of this. And there's a glass half empty and a glass half full part to this equation. So if you look at patients who had been on natalizumab for 2 years or more, prior immunosuppressant use, and have been exposed to the virus, you see the incidence of developing PML is actually greater than 1 in 100. And in my mind, this is an unacceptable risk for even patients with the most refractory of Crohn's disease, although we may want to debate that. However, if a patient tests negative for the virus, for modeling purposes, the investigators in this study assumed there was one case, but the risk of developing PML in someone who tests negative for the virus may be essentially 0, and ironically, this becomes a very, very safe therapy. So in patients who we see a lot in our referral-based practices who test negative for the JC virus by this ELISA test, natalizumab may be a great option for medically refractory Crohn's disease. Okay, so what about off-label therapies that are in late-phase IBD studies? I'm going to mention 2 off-label therapies that have been recently FDA approved for other indications. The first one I'm going to mention is a biologic known as ustekinumab, and ustekinumab binds to the common P40 subunit of the cytokines IL-12 and IL-23, which we know are major players in the cytokine cascade in inflammatory inflammatory bowel disease by virtue of the fact that they block the development of some inflammatory T cell subsets. Ustekinumab was a highly effective and now FDA-approved therapy in psoriasis. And as I travel throughout the country, particularly at large IBD centers, I see more and more people using off-label ustekinumab to treat Crohn's disease, and this is based on this phase 2 study that was published in the New England Journal of Medicine in 2012, where ustekinumab at week 4, week 6 was the primary endpoint, and week 8 showed significant benefit over placebo in terms of induction of remission in medically refractory Crohn's disease. And people, this is the kind of data that you could look at once again as glass half empty or glass half full. And if we look at the primary endpoint at week 6, the pessimists may say, well, there's only about a 13-point delta over placebo. However, I would also want to point out that this is a medically refractory population. The median Crohn's disease activity index in this study was over 300, and every patient in this study had failed at least one anti-TNF, and 50% of the study population had failed at least had failed 2 or 3 anti-TNF. So we're seeing a signal of efficacy in the medically refractory population. But there's problems here. Once again, there's access, there's cost, there's copay, there's getting this approved for our patients for an off-label indication. But I think a more important caveat that I'd like to illustrate here is that the doses of ustekinumab that have been approved in psoriasis, based on the phase 2 data that we've seen, and based on a litany of other biologics that work in both psoriasis and IBD. The doses approved in psoriasis are likely to be far lower and with less frequent administration requirements than will be effective in Crohn's disease. So the dangers in thinking about this approach is, number one, we do not have definitive late phase 2 and phase 3 data showing it's effective in IBD, and I think that's an important caveat that I'll get back to. But also, what we may be doing in these patients is as a last gap effort, is we may actually be using very low doses which can immunize them against ustekinumab if we ever find out what the right dose is and get this FDA approved. So again, this is something that's out there. I'm not strongly advocating this approach, but I was asked to talk about what to do when all else fails. Well, there's another medication, which is a pill, and this is a Janus kinase inhibitor known as tofacitinib. And tofacitinib is a small molecule that essentially is going to inhibit inflammatory cytokine signaling in T cells. This agent has recently been FDA approved in rheumatoid arthritis, and as I'm traveling around, I've heard at major centers people using tofacitinib as a last-stage therapy in refractory IBD. This paper looking at tofacitinib in a phase 2 analysis in active ulcerative colitis was recently published in the New England Journal. What was seen just looking at clinical response over here was this really wonderful dose response with the highest dose in moderate to severe ulcerative colitis having 78% response rates, 5% delta compared to placebo. So pretty impressive results here. So what are the problems? Again, this is an off-label indication. The other thing I want to point out is that although this is a pill, let's not delude ourselves. Because it's a pill, it's safe. There is a whole new litany of side effects that if this ever gets FDA approved in inflammatory bowel disease, we're going to have to get used to, including lipid abnormalities. So the rheumatologists are monitoring patients' lipid profiles. That's something in gastroenterology we haven't gotten used to yet. And there's significant immunosuppression with this agent. And I think the immunosuppression is really not going to distinguish this from the biologics by any means. In fact, there's been a very strong signal of herpes virus infections and reactivations in these patients. So this is not something to necessarily be taken lightly just because it's a pill. The other interesting thing is I've been speaking to people at IBD centers about this. Most of the open label use I've heard about has actually been in Crohn's disease. And interestingly, there is isn't even a signal of efficacy in Crohn's disease. And in fact, in a small 2A trial in Crohn's with tofacitinib that's been presented at meetings but not published, it was ineffective compared to placebo, and further dose finding is going on. So in our most refractory patients with Crohn's disease, there's really no evidence to support the use, even at higher doses, which may be associated with more side effects. Okay, so that's what's out there in terms of some desperation maneuvers in medically refractory IBD. Now, what do our patients want us to tell them works? And this also is going to go back to Josh's talk. And this goes back to the microbiota, and all our patients come in and they want to be able to say, well, let's get rid of all of these medications that suppress the immune system. They haven't worked in me. Why can't I treat myself with a probiotic bacteria? Why can't I add a probiotic bacteria to the regimens that I'm currently on? The reason is that looking at systematic reviews, we have absolutely no evidence that probiotic bacteria are effective in inflammatory bowel disease, perhaps with the exception of one probiotic preparation, VSL3, in pouchitis. But if we look at induction in ulcerative colitis, there were 5 randomized controlled trials where the conclusion is conventional therapy combined with a probiotic does not improve overall remission rates. In maintenance of remission in ulcerative colitis, there were 6 randomized controlled trials, and the conclusion was there was no significant differences between probiotic and control groups. Induction in Crohn's disease, only 1 trial, very small study, so it's hard to make any conclusion here, which was the conclusion of the meta-analysis. And in maintenance in Crohn's disease, there were 7 small trials with no evidence to suggest that probiotics is beneficial to maintain remission. Certainly there are data gaps. The hot topic is fecal microbiota transplants, and all of our patients are coming in having heard about this in the lay press, and they want this to cure their inflammatory bowel disease. And this is an area where we really have absence of data, and we're relying on anecdotal reports. There was this one abstract presented at DDW. It was a prospective study of 8 patients. This is what we're talking about in terms of the literature with this, with fecal microbiota transplant in medically refractory chronic pouchitis. The conclusions of this study was there was really no change in disease activity indices. Perhaps patients who were antibiotic resistant became antibiotic responsive in the course of this study. But the point is we're really early on. And so to conclude about this, I believe there's great promise for microbiota interventions over the next decade. However, we're at a really early stage, and I think what we're trying to do, as illustrated on this slide, is write the Shakespeare novel before we know the alphabet. I am a big believer that we will be able to identify bacteria that have probiotic properties. It may be different for different patients with IBD. I have hope that things like fecal microbiota transplants or transplants of defined microbial populations may have a role in treating IBD moving forward, but we need to relegate this to research and clinical trials. This is something that is not ready for prime time in your practices. We need to learn how to stably alter the microbiota. We need to define the alphabet before we could really benefit our patients. So this is something that I'm excited about the future of clinical trials and clinical research, but isn't ready for prime time. So here's take-home point number 2. So take-home point number 1 at the beginning of the talk was evaluate your patient on conventional therapy and figure out why it's not working. Take-home point number 2 is consider clinical trials. If you're here in the Chicago area, you have an abundance of resources at the medical center in terms of clinical trials of new agents in IBD. If you traveled here from elsewhere, seek out your academic center or your practices that are doing clinical trials, because the fact that I have to give a talk like this, and I'm asked to give talks like this, points out the unmet medical needs that we have to address in inflammatory bowel disease. I am not going to read this laundry list of clinical trials that are up and going now, But suffice to say, there are many immunologic targets, stem cell-based therapies, fecal microbiota transplantation approaches that may be very exciting in the future, and we need to learn about this in the context of controlled clinical trials. So if I could conclude this talk, point number one that I want you to remember is in a patient who is failing conventional therapies, figure out why common therapies aren't working. Point number two, in your patients who are most refractory, we really need to learn about what drugs work in what patient populations. So consider enrolling patients in clinical trials, and pretty much you could forget about everything else that I told you. Thanks for your attention.